presenting a case of marginal ulcer of scalp. Starting with the chief complaints, our patient is a 20-year-old girl by name X. She's a student by occupation, a resident of Banswara.
You move your slide. You move your slide.
I make good boost. I make good boost.
Slide is not moving.
Is it moving now?
No.
No. Please do again. No.
Only the first slide is there. I drank and I kept the glass there. Did the next slide she was asking me.
Dr. Vidush, can you mute yourself? Dr. Vidush.
Brijesh is muted.
Hey, Vidush.
Vidush, huh?
There is some background noise from the Vidush. Dr. Likhita, you have this presentation, then you can play.
Yes, sir. I'm just presenting. Yes, sir.
Please.
Let Dr. Likhita play it for you and you can read, right?
Okay, sir.
Yeah, that's better.
Wait for a second or so.
Yes, now the first slide has come.
Excellent.
Yeah, just move, ma'am. Just move the slide.
Yes.
Next slide, you move it.
Yeah, it is working.
Yeah. It is, now it is okay. Now I think you go ahead. Okay.
Dr. Nasra, please start.
Yes, thank you, sir. Can we start go to the next slide?
Yeah, start from here.
Our patient is a 20-year-old girl by name X. She's a student by occupation, a resident of Banswara, Uttarakhand. She came with a complaint of post-burn scar over the left side of scalp with loss of hair since 10 years and complaints of a mass on the left side of scalp since 7 months. She has also a history of occasional discharge, which is serious in nature since the past 7 months. Past history, this history of thermal scalp burns by fall of hot water on the left side of the head 10 years back. She had received first aid, fluid management, and wound care, that is daily dressing and debridement at a local nearby hospital. And the duration of stay at that hospital was around 3 weeks. After which she developed scarring alopecia since then, which is a duration of 10 years. Since the past 7 months, she's noticed a mass lesion, which is insidious in onset and gradually progressive in size. Initially, it was a size of 1:2, as she indicated by her hand, which is the size of a peanut approximately. It has progressed to the current size of approximately 4 into 5 centimeters. It is associated with occasional discharge, the nature of which is serious. It is a few drops per day and it spontaneously resolves on its own. There's no history of similar satellite lesions, or there are no history of any neck swellings or any fever. There's no history of loss of consciousness, vomiting or seizures or any neurological symptoms. Past history, she's not a known case of type 2 diabetes, hypertension, tuberculosis, asthma or seizure disorder. There is no history of previous surgeries other than the debridement that was done for the burns wound management. Personal history, appetite, sleep, bowel and bladder habits are regular. Menstrual history, she attained menarche at 13 years of age with regular cycles, and there's no history of substance abuse. Treatment history, hospitalization at the time of burns, as mentioned earlier, 10 years back, for which he received fluids and medications. There is no history of any LOC, vomiting, seizure, no ICU admission. Wound care in the form of daily dressing with debridement was done. History of 1 blood transfusion, and duration of stay was 3 weeks. I would like to summarize my history by saying that my patient is a 20-year-old female with progressive mass lesion over a post-burn scar, which is on the left side of scalp since 10 years, and no loco-regional or distant lesions, likely Marginson's ulcer. I'd like to proceed for examination. On general physical examination, verbal consent and adequate exposure and privacy was ensured in a well-lit room. Patient was conscious, oriented to time, place, and person. She was moderately built and nourished with a Karnofsky performance score of 90. Her vitals were stable and there were no signs of pallor, icterus, cyanosis, clubbing, lymphadenopathy, or edema. On head-to-toe examination, there was the potential donor sites for flap and graft were examined. There was no deformity or scarring. However, there was scarring of the left ear and preauricular region and a little of the neck skin. Next slide. Ma'am, can we please go to the next slide? I'd like to specific local examination. On inspection, there was an approximately 5 into 5 centimeter ulceroproliferative lesion noted in the left side of the scalp in the parietal region. It had irregular margins with mild surrounding erythema. The surface showed granular projections with scab. There was minimal discharge and crusting seen. The surrounding skin is shows hypopigmented scarring and alopecia. On palpation, the lesion is firm and non-tender. There's no local rise of temperature. It is 5 into 5 centimeters. The overlying scabs on palpation are friable, and on removing, there is minimal bleed seen. The surrounding area shows no induration, and there are no other lesions. Examination of the lymph nodes, local lymph nodes were done, which were not palpable. Systemic examination of the nervous system, respiratory, cardiovascular, and per abdomen was done, which were essentially within normal limits. There were no focal neurological deficits, and all reflexes were within normal limits. So with this history and examination, our provisional diagnosis is likely squamous cell carcinoma on a post-burn scar of the scalp, that is Marjolin's ulcer, clinically T2N0MX. So should we proceed to investigations?
Okay.
Okay, so I would like to further investigate my patient, for which I would like a tissue diagnosis and also to stage the disease. So for tissue diagnosis, I'd like to go for a air wedge biopsy, and for staging, a contrast enhanced CT scan of the head and neck region, and other routine blood investigations and chest X-ray and ECG for pre-anesthetic checkup. The CECT was done, which revealed an ill-defined heterodense lesion measuring up 5.5 into 4.9 into 2.1 centimeters in the subcutaneous plane of the scalp in the left parietal region. It was involving the left parietal bone by just scalloping only the outer table. However, the inner table was intact and there was no intraparenchymal extension. This is the CT scan, and you can see mild scalloping of the left parietal bone. Ma'am, next slide, please. The biopsy report showed that the epidermis is hyperkeratotic with marked acanthosis, and it showed features that were suggestive of moderately differentiated squamous cell carcinoma. With this diagnosis, our line of management, after ensuring that the patient is fit for surgery under general anesthesia, I would like to proceed for a wide local excision with 1 centimeter margin for oncological clearance, and to cover the remnant defect by a scalp transposition flap. After resection, this was the defect with a 1 centimeter margin. The defect was 6 centimeters into 6.5 centimeters. And the flap planned was thus: we triangulated the defect and proceeded with a local transposition flap and STSG for the donor site of the flap. Thank you, sir.
Now the panelists can start the discussion, question answers.
Okay, Dr. Baba, can I start?
Yes, sir, please. All the panelists can join the discussion. Please, sir, start, sir.
Dr. Tasveer and the team aims, you said the mode of injury is burns.
Yes, sir.
And can you, your history didn't tell what kind of burn it is, because it is very unusual to have a burn of this very small area.
Sorry, sir, we had actually mentioned it was, she gives history of fall of hot water. It was a scalp burn.
So fall of hot water, it's a scalp burn.
Yes,
So
sir.
scalp burns are usually, because scalp burns are usually, they're not very deep burns.
No, sir. Scalp burns are usually, they usually, so they extend usually up to a 2nd degree deep burn. So they don't usually involve full thickness.
So scald at the scalp, do you think that it will lead to such a deep or scarring injury? Because most of the time when we see such defects, what is the other common mode of injury you see in practice?
Electric burns, high voltage electric burns.
Okay.
They
Any
usually
other
cause
thing?
a full thickness charring burn of the scalp.
Any other thing in history you commonly see in these patients? Have you seen scalp avulsion cases?
Yes, sir.
Because it is very isolated. You said a very isolated burn that is hardly 1%, maximum 2% of area involved.
So actually, the other clinical photos, if seen, there's a scarring of the pinna, left side of cheek and left side of neck. So actually, the water has fallen onto her left side of the head and neck region.
Okay, I mean, that must be a very, very hot water. Okay. And in your examination part, yes, because
Yes.
okay, other thing is when usually we have burns in these facial areas. There is one thing which you ask very commonly from patients about history of some disorders.
So seizure disorders.
Yes, very good. So most of the time when patients in rural area or they are doing something, because of seizures, they have these isolated facial burns. They fell into these. Okay. And when you said it, what are the clinical presentations suggesting a carcinoma? Why
Sir,
can't it be just a unstable scar over a burn area?
so actually, it could be, but there's a long-standing history, that's 10 years history, and since 7 months, she's developed a lesion, which was initially 1 into 1.5 centimeters, and over a period of 7 months, it has almost become 3 to 4 times its size. And there's history of discharge, that is occasional serous discharge, and also on examination, there are friable scabs which bleed on picking off the scabs. These are all likely suggestive of malignant.
Here I will accept that there was a rapid growth. And other thing, what are the morphological presentation in case of unstable scar turning into a malignant lesion?
So other than the rapid growth on examination, bleeding, usually unstable scars will not have these scabs that bleed on healing.
No, they can bleed. Because they're unstable scars, so on minor trauma, they can have a little bit of bleeding. What are the
So also the
morphological
margins
features?
were irregular.
Yes. So what are the what are the edges and margins of a malignant ulcer?
So the different type of margins seen in malignancies are either rolled out margins, that is usually encountered in these skin malignancies, pearly edge margins like basal cell carcinoma, rolled out in squamous cell carcinoma, and
Rolled out is not exactly in squamous cell carcinoma. We say 3E. What are those 3E?
three. Sorry, sir, and 3E. Everted
Edges.
edge.
Yes. Elevated, everted edges. Yeah.
Elevated everted.
So for history and examination, Dr. Frizzy, you have any question?
Yeah, you have mentioned there is a ulcer of 5 into 5 centimeters surrounded by a scar alopecia, but you have not mentioned about the dimension of that alopecia. How much is that?
So that was around 7 into 12 centimeters, and also it extended to slightly on the occipital region also for around 5 into 8 centimeters. It was approximately 25% of the scalp, total surface area of the scalp. Sir.
Okay. So she has a alopecia. She is a female. She may likely to have, means she may want to have hair in the future. So
Yes,
now
sir.
you have done a transposition flap and you have put a graft on the other side also.
Yes,
So why
sir.
did you choose the transposition flap in this case?
Sir, the first option is we usually prefer local flaps. A rotation flap in this case was not an option because there was insufficient, there was paucity of surrounding local tissue. Because for a defect of 6 into 6.5 centimeters, it is difficult to cover owing to the already alopecia that is existing. So we resorted to a transposition flap. And to combat the resulting alopecia that is there, we have actually planned for tissue expander insertion in the surrounding hair bearing areas. And over time, we plan to cover by tissue expansions.
Again, this graft on the opposite side is going to make your tissue expansion difficult. So rather than going for a conventional rotation flap, do you have any other modification of rotation flap, Indian modifications?
So Dr. R.B. Ahuja's modification of the rotation transposition flap template may be used.
Okay, because she has
Also,
more than 50% of her scalp is still intact. Not more than 50 means on the one side if you see. So
yes.
will Ahuja's modification of rotation flap would have come and covered this defect? Because it's only 6 centimeter into 6.5 centimeter.
Yes, sir.
Now, what other modification you know about rotation flap? Any other Indian modification? Just was the original modification, 1989. Any other modification subsequently? What is divine rotation flap? Heard about the divine rotation? Divine rotation flap.
Divine rotation.
This is also by Indian surgeon only. Okay. Okay, you are telling you are planning a tissue expansion in the future, but now you have covered a graft, means that there is one area of alopecia and other side there is a graft. So will you be able to put because you need a 7 centimeter defect, isn't it? Width is 7 centimeter, length is you told 12 centimeter. So will you be able to put a tissue expander to get a sufficient scalp expansion?
Sir, the occipital area is actually on measuring, it was sufficient enough, sir, for an expander of 18 to 12 centimeters. Or it was around planned is around 350 cc volume, and it is 18 to 12 into 5.
Occipital area expansion will be difficult.
Yes, sir, we had actually counseled the patient because of obvious postural difficulties that she will face throughout the period of expansion.
In expansion, which direction your scalp will move better? Craniocaudal, or it is the side by movement?
Sir, sidewise.
Yes, normally it is the side by movement is much better in expansion. So if you put it in occipital as well as in the craniocaudal movement is much limited.
Yes,
So you will
sir.
not be able to get such an area to cover caudal. It is reaching up to this.
Yes, sir.
There is a recent modification of rotation flap, a snail flap. Mad about it?
Snail flap. Yes,
Snail.
sir. So in which the defect is not triangulated, but the pivot point moves further away, and the arc of rotation is comes a little beyond the defect, sir.
How it is planned?
Uh,
Suppose this is a 6 centimeter defect. How will you plan the?
so may I demonstrate it, sir? Should I like draw it?
You can tell also,
Uh,
or if you can demonstrate, that is also fine.
Let her draw.
Okay, sir. So if this is visible, if
Yes.
if this is the defect, sir, and this is the diameter of the defect, twice the diameter is taken on one side, and a circumference is drawn from here.
Finish the picture and come.
Yes, yes, sir.
By the way, to the other partner, do you think you can manage it with one tissue expander?
No, sir. Patient may require 2 tissue expanders
Where?
from both the occipital regions, sir. And may one on
How many
occipital.
how many occipits you have?
Sorry, sir. From one occipital region and the other one on the opposite side, sir. The hair bearing area.
You said
we can do
occipital on both sides.
Yes, sir. We can do
Then how
serial
many-
expansion also, sir. Like
Yeah, I know. How many expanders you want to insert in total?
sir, one. Usually, sir, one at one time only.
Okay, doctor. Are you ready with the diagram?
Yes, sir.
Yeah.
Is it visible, sir?
Yeah,
So
yeah.
if this is the diameter, twice the diameter is taken on the one side, and the circumference is marked such that the defect, this is around 8 to 10 times, and this entire flap is rotated, sir, as opposed to the conventional rotation flap where the arc is only 5 to 8 times the base of the triangle that is isoscellated.
Okay, here the tip is turned on itself like a snail and it is moved. So it will become snail flap.
Yes, sir. Yes, sir.
Suppose you want to put a tissue expansion. What type of tissue expander? What's the shape you will use?
So usually rectangular expanders are used as we get maximum expansion and for the flap to be advanced.
Okay, here what size you will choose?
So here we will calculate the area of defect or the scarring alopecia that is there and the resultant donor area of alopecia due to the grafting. So in the follow-up, this patient, we have got a 350 cc by volume and it was 8 into 5 centimeters.
You have a 7 into 12 centimeter, isn't the defect?
Sorry, 8 into 12 centimeters.
8 into 12 centimeter.
8 into 12 centimeters.
So your base width will be?
Sorry, sir.
So what should be the base width?
The base
the
8,
implant
sir.
you will be choosing?
8
centimeter. Okay. Suppose you wanted to put a 2 tissue expander because the length is not sufficient.
Yes,
So
sir.
will you put it in a two separate compartment or will you put it in a single cavity?
Sir, two
Because the length is
separate.
12 centimeter, you wanted to put it into separate implant. So will you put it as a in a single cavity or you will be separate cavity for the expander?
So you're asking two expanders to be inserted in single setting. Or
If the lengthwise, suppose you are
Length.
not getting that length,
Okay,
you
sir.
wanted to put it to nearby, will you put it in the same or will you put it separately?
So if we put it in the same cavity, then we will gain a little more length, because if we have to make two separate cavities, then we may lose some intervening tissue that is there owing to the suturing.
When you're putting it in different, this is like occipit and parietal area, means the temporal area, it is a different one. But suppose it is in the same length, it is better to put in a single cavity. Otherwise, you will have a bridge in between, which is not expanded skin and it will not move.
Skin. Ah, yes, sir, due to suturing.
Okay, in the Marjolin ulcer, will you expect any lymph node?
So it is unlikely, because the burns, the scarring due to the burn, these have usually obliterated the surrounding lymphatic tissue.
Okay.
But
In
if
this
it's a
case, which lymph node will be likely to
poor
involve?
prognosis, so these preauricular lymph nodes, occipital lymph nodes,
Okay, normally lymph nodes are not seen in Marjolins because of the scarring already.
obliterated, yes, sir.
Why it is called Marjolins?
So this was actually first described by Jean Marjolin, sorry. So it was named after him, and hence it is called.
So why margarines also develop? What is the pathophysiology? And why
So
it is on scars?
these develop on chronic long-standing scars, most commonly burn scars. It is owing to the chronic irritation and periodic inflammation that occurs.
Is it inflammation or something else? There will be scars which are there are certain types of scar on which margulins develop. So what is that kind of scar?
Unstable scars.
Yeah. So why does unstable scar have propensity towards cancerization?
So due to the chronic irritation or chronic inflammation that is going on.
Irritation is one, and the other thing is that there is constant stimulation to epithelialization, because there is breakdown of the epithelial layer.
Breakdown, yes.
Again it breaks down. So there is a constant this thing. You said that there is erosion of the outer table.
Yes, sir.
So in your definition of wide local excision, you will keep the inner table.
So the algorithm usually followed is you have to resect till one layer deeper. If it is not involving pericranium, then you shave off the pericranium. If the pericranium is involved, then you take the outer cortex as well. If the outer cortex also comes positive in your frozen section, then you proceed to inner table resection as well.
So in this case, the outer table was intact.
No, sir, the pericranium had come positive, so we had to remove just the outer table.
In the CT, the outer table looks to be. You had done a frozen section.
Yes, sir, entropy had sent a sample.
So if you do not have the option of frozen section, and your CT shows that the outer table is gone, the CT is quite clear that the outer table is eroded.
Yes.
And there is a lot of wisdom of taking out the inner table as well. Yes, you have the advantage of having but one thing is very not clear. Bone biopsy takes a long time. It's not easy to do in frozen section.
Yes, sir.
Bone biopsy is not it's not an easy thing to do. It takes a long time to decal it and then do the exact tissue biopsy. But in this case, it is not very easy to opine on frozen section. So there is a lot of oncological wisdom in taking out the inner table as well. So in case if the inner table is involved, inner table is removed, what are your reconstructive options?
So they can be, you can do both. The bony defect is to be reconstructed. The options are either autologous or alloplastic bony replacements. So autologous bone can be taken from the iliac crest when you take ancillary bone or split rib cartilage. And alloplastic med-pore implants are available, which are made of methyl methacrylate. This can be seconded with a flap cover. So cranioplasty with
only option is an iliac crest bone graft.
the rib can be taken, sir.
But
Split
we have
rib.
the whole scalp open. You
No,
can
you
take
already
cranium
opened the
also.
skull.
The calvareal bone graft also can be taken.
Yeah. So how will you excise this lesion if you have to take out the bone also with it? Just tell me the steps. How will you do it?
The steps of the surgery we will
Steps
pick.
of the resection along with the bone.
Okay, sir. So first the patient will be placed in position.
Start from the incision only. That's it.
Incision. So first we will mark the incision with 1 centimeter margin clearance. Since it is highly vascular, we like to give a tumescent infiltration with ADR and epinephrine. Sorry, lignocaine and epinephrine. And we would wait for 7 to 10 minutes, after which we would proceed with incising along the marking. Once the and we would raise up to the pericranium, and once the frozen has come positive, we would proceed to removing the outer table. Sir, for this we actually had help from the neurosurgical team.
I said that you do not have the option of frozen section.
Okay,
So
sir.
how will you do it? You will obviously then your planning is for taking the lesion out
Yes, sir.
with the bone. So that's the steps I asked for.
So to take the bone out, we could use a burr or oscillating saw and to do the bony
Have you ever
resection.
seen a craniectomy being done?
So we have seen full thickness where burr hole is done. A jiggly saw is inserted between the two burr holes, and then the craniotomy connecting all these burr holes, the vault is removed. Sir.
So would you? Another question is, would you take the help of the neurosurgeon or do it alone?
Sir, I would at this stage definitely take help of a neurosurgeon, sir, to avoid.
First, see, you're planning a case, so planning the manpower also is important.
Yes, sir.
It's not a very easy task to take out the bone along with the lesion.
Yes, sir.
So it is better that, and if what things can go wrong in this if you are doing this, taking the bone out?
Sure, they can be, firstly, they can be bleeding, they can be breach or end of the dura and the meninges. If it is uncontrolled burring, it may also damage the brain parenchyma. They can be risk of post-op meningitis.
What are the instrumentation you need in case to do this?
So for a burr, we need a burr and jiggly saw, or if we have a oscillating powered saw, that can be used. So.
You can use a side cutting saw to cut the calvarium.
Yes.
You can.
Yes, side cutting. Side cutting.
Side cuttings.
You need a special hand for it.
Handle,
And any single stage operation, any vascularized transfer that you can do, which can reconstruct both the bone and the soft tissue.
So free flaps that are osteocutaneous may be used, like the osteocutaneous radial artery forearm free flap or the osteocutaneous free fibular flap may be used.
But they will not give you a flat bone.
So scapula with
Other one.
Scapula. Iliac, so free iliac bone.
Yeah, DCIs. Yeah, correct. How will you fix the bone in this case?
Plates, mini plates may be used.
Size of the plates, size of the screws.
2.5 millimeters. Sir, 1.5.
In case of tissue expander, you said tissue expanders for this. You will have a anteriorly based flap or a posteriorly placed flap in case of side-to-side movements of the expanded flaps. Which is preferable?
So the aim would be not to move the hairline, so we would keep it anteriorly based.
Fine. Dr. Pratap?
So can you please show me that photograph where you have made the markings for the flap? So is there a possibility that we can do this flap based on the left side?
Based on the
Left side
patient's,
scalp. Yes,
patient's left side, sir.
yes. Yes, yes.
Which is
Yes.
Patient's left, sir. Actually, this is the area where she had sustained the burns. Even the pinna actually is scarred and deformed.
No, even if that is the case, since you are planning for a tissue expander at a later point of stage, you are raising this flap, your requirement for tissue expander where you want to place it will be again pushed. You'll be losing good opportunity of the native tissue of the tissue expander. Whatever is possible from the left side, that means the small side, would be beneficial in the next surgery for us.
Yes,
Whether
sir,
you
but
do it based
there was a
posteriorly
little
now.
paucity of tissue, sir. It was the defect was 6 into 6.5, so we were not getting sufficient tissues.
No, we may compromise a bit by raising it based posteriorly also. So anteriorly you can go, because in the next stage when you put tissue expander on the right side and you expand this scalp, at that stage again you can re-put this flap back. Always keep in mind, if there is a chance, whenever that native area where you want to use for tissue expander, we will not get that much opportunity. Since our first option is use that widest area, if there is a possibility we can avoid it, always let us try to avoid it. If it is not possible, that is a different story. So in this case, as you were saying, the scar is around 8 into 12 centimeters, as alopecia that you were saying.
Yes, sir.
The size of the scar. So you were saying what size tissue expander do you want to put?
So it was 8 into 12.
So 8 is the transverse diameter, 12 is the craniocaudal, longitudinal, right?
Yes, sir.
So the tissue expander that you want to place roughly should be more than or?
More than the size of the, at least 1 centimeter more than the defect, sir.
So what is the height of the tissue expander that you want to use?
So it was 5.5 centimeters.
No. Critically, my question to you is, what is the gain when you're putting a tissue expander in the scalp or anywhere? What is it that you want to gain in the tissue expander? Is it the height, length, width? Where do you gain the tissue from?
Projections, height.
So roughly when you want to remove a tissue or 8 centimeters, you should have a tissue expander where you are putting that height for at least more than 8 centimeters. That should be your aim. That height that you gain is the tissue that you're going to push laterally, right? You got my point?
Yes, yes.
So, always try to put a larger implant larger than that. That is what I'm trying to say to you. So in this case, on the lateral side, after you remove this thing, do we see that bone exposed?
Yes, sir. This is after removing the outer tape.
Is the bone exposed?
Yes, sir.
Is there a bone exposed there, or is there no bone exposure?
So there is bone exposed, sir.
Where, sir? Over defect area, where, sir?
Yes. From the photo, I'm not able to clearly understand. Is that
Yes, sir. Bone is
outer cortex, or is there no outer cortex?
Outer cortex is removed, sir.
Oh, fine.
Okay, one more question. Suppose the patient doesn't want a tissue expansion, but she wanted some hair in the frontal area to camouflage her this alopecia. So what flap you can use in such cases? Or have you heard about jury flap?
Jury flap, yes, sir, it is based on the posterior branch of the posterior auricular artery. It uses
What is that? Tell the name of that, full name of the flap.
sir, it is an islanded flap that is based on the posterior branch of the posterior auricular artery.
Posterior branch of the superficial temporal. It's a temporoparieto occipital flap, which can be turned and covered in the anteriorly frontal hairline you can view. So can you do a Jury's flap on either side simultaneously, or suppose she want more area?
Sir, on her right side there is no alopecia, sir. The
No,
front
if she
area.
wants frontal area also or some more area to be covered,
Okay, sir.
can you do simultaneously on both sides temporoparieto occipital flap?
So splinting will be a problem. So I
Compromise vascularity also.
vascular.
So it will always done as a two separate states.
So how do you finally evaluate once you have put your patient on tissue expansion? One was the base diameter and the projection. How much, if everything is going well, how long you will keep on expanding? And what will be, how will you estimate that enough expansion is achieved?
So clinically, we will ask at each time they be infiltrating, we will ask the patient if they're developing any signs of any pain, and we will see if and objectively we will look for any signs of skin thinning, erythema, or infection, or any gaping. Ideally, it is told that
what is the best? Yeah, what is the best modality while doing these expansions, or is there any other? What are the warning signs in tissue expansion? Can you see anything clinically?
symptoms of pain, local site examination may reveal erythema, skin thinning, and immediate an emergency would be exposure or extrusion of the implant itself.
That is very late when you are doing it. Clinically, can you see something that if it is not happening, your patient
pallor.
can this expanded flap? Yes. So that blanching, if that blanching has disappeared, clinically you have to see that it should at least have some blanching and that return of hue. And then how do you, suppose you had a 10 centimeter defect and then you have calculated, do you exactly expand up to your calculated area or do something else?
Sir, not
how do you
exactly. So
estimate
actually, when when you first we have a defect, you have to plan the flap for an area that is 20% more than the defect.
why that 20% more you want?
So there may be flap contraction later, and also during surgical manipulation or tension, there may be limitation of some movement. So 20% is kept extra, sir.
There will always be flap contraction. You have to take that extra amount of expansion whenever you're planning. Yeah. Is there any other modality of treatment? Suppose your expansion fails and you have done this transposition flap.
Yes, sir. So there for hair resurfacing, hair restoration, sir.
Of course, if I ask the because see, what are the dangers? If you have done only a small transposition flap, rest of the area is still unstable. So how will you treat? if you do not do expansion?
Sir, hair restoration surgeries, we can offer the patient FUE or FUT, but unlikely to have a successful result in previously scarred skin. Other than that, non-surgically, we can offer the patient if they're motivated to wear a wig. Or
Of course, for what will you do for this unstable area? Because that you have not included that unstable area in your flap. So how do you convert an unstable area into a disease available right now?
sir, we can excise and graft, sir.
Yes,
But
you can do a tangential excision and graft it. That will give it a relatively better area, which will be, I mean, which will not be easy, which will not be easily ulcerating. So that will prevent this thing. And of course, any other thing which is recently available for treatment of unstable areas. In some recent advancements of treatment of unstable areas anywhere.
lasers.
I mean, you have not seen all these artificial dermal supplements,
Double matrix.
dermal matrix.
Grafting
Yeah.
later. Yes.
I mean, those can also find a place in such managements.
Can I add some point?
Yes, sir, Venkat sir.
Yeah, not exactly related to the treatment, but while recording or presenting, the measurements of the wounds or if possible tumors also are to be taken in two directions, in the sense you have to keep two tapes, measuring tapes. Tapes are millimeter tapes, same, in two directions at 90 degrees to each other. That means one, say for example, coronal, the other sagittal, okay, in two directions beside it. And then you can ask somebody to hold both the tapes, or you can put a small cello tape on that and then take a picture. Then it is a proof, pakka proof, and easy to communicate the dimensions. That is one important point in plastic surgery photography. Over. Thank you.
Thank you, sir.
What would have been done to prevent this situation for this patient during the primary treatment of burns? When the patient got burned, what could have been done that the person wouldn't have landed up like this?
So they could have done debridement followed by grafting, skin grafting.
And yeah, that's one. Anything else?
Skin grafting will not give hair.
No, sir.
Anything else that could have been? She was treated in a hospital. You said she was admitted for 3
She was
weeks.
admitted in a local hospital, yes. So she gave history of being admitted in a local hospital where for 3 weeks, where she was
So
given.
what was the mode of treatment? It was only dressing?
Yes, sir, it was
Yes, sir.
only serial. She
Serial
told there was
dressing.
dressing and superficial debridement was done.
Dr. Brijesh asked you a question. It is very unlikely that a scald burn on scalp, which has very deep hair follicles, will have a wound like this.
Yes.
It's possible with an epileptic falling on fire. It's possible with electrical injury, but with scald burn, it's very unlikely to land up like this. So, can you tell me why the person landed up like this? What could have happened to the wound?
So it would have it would have been for a longer duration. It would not have been adequately debrided or dressed, and the inflammatory process would have been prolonged. Even after maybe it epithelialized, she did not take care. So there would have been repeated trauma. Or
that repeated trauma is later on.
yes.
See, the only reason that can happen is the wound must have got converted from a second degree deep to a full thickness burn because of poor wound management.
Yes, yes.
Scalp is a very thick hair bearing skin. The hair follicles are pretty deep, and it can manage. It can stand a lot of denuding of epithelium. So epithelialization is very good in the scalp. In this case, you're saying that it is a scalp burn and the person landed up with a scar. Now the scar looks like it has healed by contraction because the what does the vitiligo patches say? The vitiligo patches basically say that the wound is very deep. So the wound must have got converted and took a long time to heal. So a good conservative management also could have saved, and obviously grafting also is a very good option. Had it been a full thickness or a second degree deep. What is the disadvantage of doing a primary excision in scalp?
Disadvantage of the primary excision.
Primary excision grafting in scalp is generally reserved. It's generally not done.
Of the resultant alopecia.
Yeah, so it's not a very good idea. In this case, if you think it is a scalp burn, a good dressing would have saved it. Now you tell me, what is the ideal way of dressing such a wound? What are the attributes of an ideal burn dressing?
So firstly, the wound has to be thoroughly irrigated with saline, and dressing should be done with a moist, non-occlusive, non-adherent dressing.
And then it should be non-adherent. It should be moist.
Moist.
Then
it should not it should not have any communication with the atmosphere to prevent secondary bacterial infection.
It should prevent evaporative loss.
Evaporative loss, yes. Fluid
and
loss.
Then the most important thing, it should have what properties? It should be antiseptic. It should have antibacterial properties.
Antibacterial.
And breathing. That dressing should allow breathing. Both the moisture as well as
yes.
Correct.
Yeah.
Can you get any product which can you can do excision and temporize the excised wound? You don't have graft. What is the product that can be used?
Collagen dressing we can also apply.
I am telling you that you have excised the wound and you need a substitute. You do not have homograft. Ideally speaking, you should put a skin graft on it. You do not have the facility of a homograft. What will you put instead of that? Is there any product available in the market?
Sir,
fish.
Which has similar characteristics as a skin. Yeah. So what are the layers in Integra?
So it is bovine collagen with glycosaminoglycans over a silicon layer.
What does a silicon layer do?
So it helps in restoring or holding the moisture.
Okay, fine.
Back to tissue expansion, in which plane do you place the tissue expander?
Subgaleal layer, sir.
Why not subcutaneous?
So for hair follicle.
What will happen?
In subcutaneous layer, hair follicles will be damaged. That's why we have to place in subgaleal layer.
Of all the areas of human body, which area is the best for tissue expander?
The area with thin and pliable skin are more amenable to tissue expansion. So
No, which one? No, arms, body, scalp. Where do you think is it good?
Neck.
extremities and
Neck, sir, abdomen, neck.
You think extremities are better to expand than scalp?
sir, back, neck, and face are usually more amenable. They have more thin and pliable skin as compared to the scalp.
What exactly, I mean,
The scalp is the best because the underlying surface. Scalp is the best because the underlying surface is bone and it is not
Rigid,
yielding.
rigid
So
base, sir.
the only area where we can, the whole force of the tissue expander is towards the outer skin. So it's
Outer skin,
advantageous
yes.
for us. Arms is the worst. They don't yield much. The maximum complications that we see in tissue expanders is when we place them in the limbs. That is not
Yeah.
ideal.
Extremities are the worst areas.
And then what is the principle behind tissue expander?
So it works on the principle of creep. There's biological and mechanical creep. Mechanical creep is the stretch that occurs due to the physical pressure that is applied, and biological creep is the actual proliferation and increase in number of the cells. The resultant tissue has usually a thinned out dermis, epidermis, and the fat is atrophied, and the hair follicles, however, remain the same number, but they may be less dense as the same number of hair follicles are distributed over a expanded skin.
Tell us some examples of natural tissue expansion.
The pregnancy.
Yes, any other?
So tumors also, soft
Tumors.
tissue sarcomas.
Yeah, so benign tumors in pregnancy. You get a very good tissue expansion.
Can I have few questions? Hello, Dr.
Yes, sir.
Umar.
Yes, sir. Go ahead.
Can I have few questions, sir?
Yes, sir. Answer.
Please. Oh, thank you so much. In fact, in the history of this patient in clinical examination and in management, I have few comments and few questions also. In the history, I've told a 10 years girl, the history from the mother or the father from whom you have taken about the nature of the burn.
History is from the mother, sir.
Mother. Can you not reconfirm it from the father also? Because as per the, it is a very unstable and such a area with a deep burn, mostly it cannot be from the scalp. So it is unbelievable in that nature. So that is one point as far the history is concerned. Second is, when you are going to plan for such things, the planning has to be done in planning in reverse. So the apparent defect and true defect has to be made out, and a template has to be made it. So you should have a length cloth, and all the templates has to be made out and shown here. And the photograph you have taken, it should have been taken little in other angles also, which has not been done here. Because the patient belongs to you. In exam also, you will have the patient in a long case. So all the details has to be made out. Thirdly, as far as the management is concerned, it is not just managing the ulcer or this squamous cell carcinoma along with the different tissues. So you have to plan it as a whole. Post-operatively, what management has to be done? It should be by radiotherapist and chemotherapist and the tumor board, if you have the consultant with you. So that whole treatment plan has to be made. As far as the surgical plan is concerned, you ought to take the neurosurgeon with you in this case. I had a case also, a neurosurgeon has to be taken. And as far the treatment part is concerned, it is not the external cortex or diplopy is involved. The internal diplopy must have been involved. Or for the most common problem with this patient will be recurrence. Later on, you will find a young girl having a recurrence. In that situation, it will be too difficult to treat. So the recurrence part taken into consideration, it may be the internal diplopy and you have to take care of the dura also. It may be the dura may be exposed and the neurosurgeon can give you the support of putting a dura patch or a autogenous tissue in form of pressure letter, whatever you can manage with. That will depend on situation. And as for the bone, never a giggly saw is used. in scalp to do the osteopathy. It is always the rongers, the neurosurgeon, they have the rongers, burr with nibblers. So there are different types and they can needle it, burr it, and they can take it, remove it. It is not possible, otherwise it will damage unnecessarily the dura and also the sinus also sometimes. So that part is, I think you must not have seen how neurosurgeon does it. We always take support in these cases. And if there is a bleeding or a dura rent, that has to be prepared before that. You should have a dura patch or you should have a tensor fascia letter to be reconstruction for the dura. These are all has to be made before before the planning is made out. And thirdly, as far as the bone is concerned, you can manage with nowadays the titanium mesh are available, so that can be a good procedure for the bone. Because to take a bone from a donor area and getting it, and you don't know what about the status of the recurrence. And many a times, if you have the facilities, then you can have a PET scan to be damn sure about if it is available and patient can have it in a government hospital, it's free of cost. So operatively, you can assess whole of the patient. There is no recurrence anywhere. So that is a very good tool nowadays available with government hospitals. Post-op also you have to repeat it sometime if you require it. So these are the, whenever you talk about the management, it should be pre-op, intra-op and post-op also. It cannot be restricted to only one year. And this is a multidisciplinary approach for this. And rightly, one of the panelists rightly told that the planning in reverse with the true defect with measurements has to be made in different options. So the left side is not been seen properly, so it is difficult to really make out and assess for a flap. So all these things, I think in examination, you have to take care of how to have all these as a plastic surgeon to plan it properly like an architecture. These are a few comments I have to give. I hope the panelists
Thanks
are
a
doing.
lot, sir.
Thank you so much.
Thanks a lot, sir. The same query has been raised in the chat box also. It says resection area shown here seems to be inadequate. Bone exposed, probably both tables need to be resected. So cranioplasty will be needed and there will be little scope for the local flap use. Cranioplasty can be done by separate ribs covered by any muscle flap, maybe rectus abdominis for better options. Any take on this comment of the panelists?
No, I think this if you don't treat the whole unstable area, local flaps like transposition flaps can very well cover it. And as many times we do a delayed cranioplasty, so the immediate reconstruction of bone is also not that important. Okay, that can be done later on. So, I mean, there are multiple options of treatment, and I don't think that there is no place of local flapules. Definitely, they are mainstay of treatment in most of our centers for these cases.
What about the resection? Does it seem
Yeah,
adequate?
resection, of course, if the bone is involved and it will on the safer side, both tables should be resected. Yeah.
Okay, thank you. Dr. Likta, we are done or we have some time?
Yeah, sir, just 1 more minute left, sir.
Okay. Then panelists can continue for discussion for 1 more minute. Any questions or?
So, have you seen what happens to cranial bones after expansion?
They may be scalloping due to the overlying pressure.
So do you need to do anything for that indent which happens post expansion?
No, sir, it's not required.
Yeah, of course, it is not required. It actually regains that shape. And most of the time, you don't need to do anything. When you take out your expander and you see that area, it looks like it is very much depressed, but you don't need to do anything for that.
Can you have
Yes,
option
no.
for a free flap here in this case? If it is, would be
Yes,
the
sir.
suitable free flap.
Yes, sir. Since it is a small area, we can go for a radial artery forearm free flap or faciocutaneous. But again, it comes with donor side morbidity since she's a girl.
आपको दिखाओ तो किधर आपको
Can I ask a question? Yeah. This is a young girl,
Please, sir.
and
Yes, sir.
we are dealing with the malignant part, fine. But ultimately, she will require an anterior hairline devoid of depigmented scar. So, if you have to, manage in that way,
Yes, sir.
and if you later on think that you will use a tissue expander, how do you plan the tissue expander so that the anterior hairline is maintained as well as the depigmented scar is removed?
So we could use a pre-expanded free flap and attempt to graft on that.
So you have adjacent adequate hair on the right
Okay.
side.
Yes, sir.
It's a hemicranial scalp loss.
Yes, sir.
Okay, only on the left side, not truly hemicranial, but right side cranium from midline onwards is intact.
Yes, sir.
So how best you can use it so that the anterior hairline is also maintained in a young girl as well as the depigmented scar is removed.
Can I ask one simple question, sir? Can I ask one simple question? Anybody?
Yes, please, sir. Yes, please.
Yeah. The candidates, can you please enumerate the shapes of the tissue expanders you know?
So there are rectangular, there
Okay.
is spherical dome shaped, then crescent shape.
Yes. Any other? Crescent shape extension is horseshoe shape. Okay.
Horseshoe.
Then why I ask this question is, why can't you think of that horseshoe shape or crescent shape on the back of this patient, which extends into the sides also?
Okay, sir. So actually the right hemicranium which is seen in the area, that is was used as a transposition flap.
Already?
Yes, sir. Yes.
Okay. Can you expand the transposite flap?
So it is the type of flap, it's a local flap. So it uses adjacent tissue. The planning of the flap is the defect is to be triangulated, and into an isosceles triangle, the adjacent margin is extrapolated. The base of the triangle should be marked as the width, and pivot point is marked. Once the pivot point is marked, then you draw a parallel line to the adjacent base of this triangle, so you will get the flap. The flap slides onto the adjacent area, and the donor site is grafted. The advantage is that it has lesser
That's enough. That's
tension.
enough. That's enough. The corollary is, what is the difference between the flap you are describing and the skin, expanded skin you are transferring? That means you are cutting off the you are cutting off the blood supply on different sides to the flap. When you are expanding, you are taking the whole blood supply there.
Yes,
okay.
sir.
That my point is over. I think that Umar, you take over.
Thank you, sir. So I think we are done with the long case. So let us move to the questions from the other teams to the students. Dr. Likhta, you can call the rolls.
Yes. Dr. Madras Medical College. Jipma Pondicherry.
Sir. What is where will be the pivot point in the rotation flap, and what will happen to the pivot point when we give the back cut in the rotation flap?
So the pivot point is taken at times the radius from the adjacent side of the isosceles triangle in a rotation flap, and when you give a back cut, it moves. Moves medially or further away.
Okay, thank you. Okay, thank you.
KGMC Lucknow.
Hello, good evening, everyone. Can you please tell me about management of scar alopecia? Where we can use, is there any percentage of alopecia when we can use tissue expander? Are there any guidelines?
Usually more than 30% of when there is a scarring alopecia, more than 30% of the total scalp area, it cannot be resurfaced by local flaps. That's when we resort to tissue expansion or distant flaps.
Actually, it is 20 to 50% we can use, and up to 75% we can use 2 expanders.
Thank you.
Team 4, Stanley Medical College.
Hi, my question to you is, can you tell about the blood supply of scalp?
The scalp is supplied by from anterior to posterior. It is by the supratrochlear and supraorbital artery, which are branches of internal carotid artery, and on the lateral side by the superficial temporal artery, the posterior auricular artery, and the great occipital artery, which are branches of the external carotid artery.
Okay, thank you.
Team 5, AIMS New Delhi.
Good evening, everyone. Can you describe what is 1 to 3 centimeter scalp advancement flap rule?
I'm sorry, I'm unaware.
So it was a study done in cadavers which described that if advancement flap was performed, once the Galilean scoring was done, there was 1 centimeter extra advancement that could be achieved, and only if the outer cortex of the clavarium was removed, there was still 1 more extra centimeter by which the flap could be advanced. So that is 1 to 3 centimeter scalp flap advancement. Thank you.
Thank you.
Team 6, Bangalore Medical College. Team 7, CMC. Team 7, CMC Vellore. Team 8, Safdarjung Hospital.
Good evening. Can you tell me about the Harrison's classification of skull burns?
Harrison's classification of scalp burns.
Skull burns.
Sorry.
So basically there are 4 types. Type 1 is when there is total skin loss but the pericranium is intact. Type 2 is when there is total skin loss but even the pericranium is involved. Type 4 is skin loss with involvement of outer table, and 3 and type 4 is when there is total skin loss with involvement of both plates of the skull, that is both the outer and the inner table. Thank you so much.
Thank you.
Team 9, RML Medical College.
Good evening. My question is, could you enumerate a technique to advance the scalp flap?
By Galilean scoring?
Do you mean methods to increase the reach, like Galilean scoring, back cut, excision of a Burroughs triangle?
And what amount of advancement can we expect when we do the scoring?
1.75 centimeter.
Yeah, that's right, around 1.6 centimeters. Thank you.
Team 10, Keelpock Medical College.
Good evening. Can you tell me about the trichophytic incision?
Yeah. So usually we have to do excision in a oblique plane so that hair follicles will not be damaged.
The incision is parallel to the direction of the hair follicle to avoid incision scarring alopecia.
Okay.
And you bevel it.
Thank you.
Team 11, Gandhi Medical College, Hyderabad.
Hi, good evening. Team 10 Gandhi here. So my question is, what are the layers that are found in the tissue expander capsule?
It has a fibrocollagenous layer, which is fibroblasts, and a granulation layer.
So there are 4 layers. The inner layer formed by fibrin, and second layer, central layer formed by myofibroblasts. Third, transitional layer formed by collagen fibers, and fourth, outer layer formed by vascular layer. Thank you.
Next team, Mamsi, New Delhi.
Good evening. Can you please tell about the Macaulay-Burn alopecia classification?
I'm sorry, could you repeat yourself? Not audible.
Macaulay's classification of scalp alopecia was born. Macaulay-Burn classification, scalp alopecia.
Sorry, you're not audible.
Please, sorry, we could not hear you. If you can put it in the chat box, later on we can take this question. You can put it in the chat box.
Can you
You are
please
not
tell me
audible.
Macaulay-Burn alopecia classification?
Okay.
Macaulay.
Burn alopecia classification.
Yes, Macaulay's classification of scalp alopecia.
Macaulay's burn alopecia classification.
Yeah, Macaulay's.
So there are 4 types. The type 4 is total alopecia. 3 is patchy alopecia. Type 1 was that is less. It is single segment, and type 2 is multiple patches.
Yes, thank you.
Next team, NIMS Hyderabad. Ganga Hospital, Coimbatore.
Good evening. Could you name a few classifications for hair loss patterns in female?
Hair loss patterns in only restricted to females?
Yeah, female hair.
There's Fitzpatrick classification.
Sorry?
The Fitzpatrick.
No, actually, it is the most commonly followed is a Ludwig classification, and there are other classifications like Ebling and Rook, Savin, and Olson's classification that describes hair loss patterns in female.
Thank you.
Thanks.
AIMS Bhubaneswar.
Good evening. Can you tell me the disadvantage of raising the scalp flap in the subcutaneous tissue plane as well as in the subgaleal plane?
So in subcutaneous, there's higher risk of damaging the hair follicles. So there's a greater risk of alopecia.
And
in flap thinning, and there is more chance of ischemia or necrosis.
Yes. And what is the disadvantage of including the galeal layer?
So it is limited. It is more taut. So there is limited advancement or
Yes, it is inelastic and
limited cover, less
non-responsive.
elastic.
Can you mention few goals of scalp reconstruction?
So one is to provide a good stable cover. Second is to ensure it is hair bearing, it is aesthetic. Third, you have to ensure that the flap cover is in blood vessel is included.
And we'll try to maintain the hairline and contour of the scalp.
Yes.
Okay, thank you.
We're done with the questions by other teams. So can we go to the next session?
Yes, please. Go to the next spotters now. This is spotter number 1. The panelists can join for the question, answer, and discussion.
So do we start? It is a case of...
Yes, please, you diagnose and tell the findings. Meanwhile, panelists will be ready with discussion.
It is a complete cleft lip and palate. View 3, right-sided. The findings are there is right side alar flattening. The alar base is displaced laterally. The columella is medial to the non-cleft side. There's flattening of the dome, nasal dome. There's a discontinuity of the lip, and the median tubercle or the central lip element is deviated to the non-cleft side.
This is bilateral.
Why do you think that it is a unilateral cleft? It clearly looks like a bilateral cleft. So what are the things which are visible? Now I'm telling you it's a bilateral cleft. What are the things which are visible to make a diagnosis of bilateral cleft?
Prolabium and premaxillary.
Yeah, so you can see what are the differences in columella in a unilateral and bilateral cleft, or differences in premaxilla.
The columella in unilateral, it will be shortened and deviated to the non-cleft side.
Because you see there's a variety of cleft presentation. So it can be, I mean, this is not a symmetrical bilateral cleft, but you can see the part which is visible. You can see sides. It is taking off, and premaxilla is.
Dr. Mishra, your strength is poor. Power connection strength is poor. Can you talk a little closer to the speaker?
Okay, sir. Okay, sir. Am I audible now?
Yes.
So you can why there is prolabium is like this in bilateral cleft.
So because there is non-union of the lateral lip elements to the median tubercle.
So why it comes up, or it is not aligned to the other arches usually. What is the basis of these deformities in a cleft lip patient?
So there is lack of the normal anatomy. The orbicularis oris muscle is deficit. It's not
So basically, the restraining muscles are not there, and it's a differential muscle pull. So how do you manage these patients in the first month of birth?
The first month is firstly we have to counsel the parent regarding feeding and nursing. So we tell them to feed in propped up position, 45 degrees. After feeding, the child has to be burped frequently, and
multiple frequent feeding should be
advised, and taping may be done. Taping. Non-surgical.
So we are not sure of whether it is it's a complete cleft lip and palate, or it's a cleft of lip alone. But what you can see from this, probably it is a complete cleft lip and palate. So how would you classify this if it is a complete bilateral cleft lip and palate?
So there are multiple classification for cleft palate, like view classification, Nagpur classification, Laser classification, and Karnahan classification.
So practically what we use a Nagpur classification.
Yes,
how,
sir.
What is the basis of Nagpur classification?
So it is either the 1A is lip one is lip, one A is lip with the alveolus, 2 is cleft palate alone, and 3 is lip alveolus and the palate involved.
What is cleft of primary secondary palate? What do you mean by primary palate and secondary palate?
Which is anterior to the incisive foramen.
It's a primary palate, and posterior to incisive foramen is secondary palate.
Okay, so 1 is cleft of primary palate, 2 is cleft of secondary palate, and 3 is cleft of both.
Cleft lip, yes.
Primary and secondary palate both. So in first, can you do any maneuvers in first month or first 2-3 weeks to improve the results in a bilateral cleft lip and palate?
So there may be non-surgical maneuvers like lip adhesion, taping, nasoalveolar molding.
So you will do a lip adhesion in first month?
Yes, sir, can be done.
So ideally, what is the older rule of 10? When do we operate such patients?
10 weeks, sir.
So first month, we don't recommend any surgery.
Yes. First month is a non-surgical vision.
Any other?
So
Rule of 10.
nasoalveolar molding is one.
Sorry, sir.
So
10
lip
pounds.
adhesion, taping, nasoalveolar molding, Latham's device, gingivoplasty.
Surgery is out on first month.
Non-surgical, sorry, sir.
Don't operate.
Any questions from the other panelists?
What are the two major advances which happened in the last 50 years in management of bilateral cleft lip? Two major advances.
In the surgical management, so
In the
using
management, for
modification.
management of in the last 50 years, there are some changes happened from the conventional managements. What are those things? Two major advances. One you have already mentioned.
So
Surgical thing.
the gingivo periosteal.
Pre-surgical orthodontics is one. Nasoalveolar molding is the one which has developed, and one more in the surgical technique. Any changes there from the previous one?
The molars
modification.
What do they do in that one different from the conventional surgery?
There's a backcut that is extended onto the columella.
It's the involvement of primary nasal correction. What do we mean by the columella in the nose?
Columella in the nose, sir.
What is the meaning of columella in the nose?
Soft fibrofatty tissue, sir.
So conventionally, we correct the columella by the fork flap. But nowadays, are we doing that one? So what are the Mulliken's principles of management of bilateral cleft lip? There are 5 principles given by Mulliken.
So one is to establish continuity.
Yes.
Bilateral symmetry. Anatomical alignment of sorry, sir.
So basically, when you approximate the lower lateral cartilage and fix it, the automatic and rearrangement of the nasal tip skin, your columella will come back. Columella is not in the, you don't need to recruit your tissue from the prolabium into the columella. Columella will be, once you approximate the lower lateral cartilage, columella, it will automatically form. That is why it is called columella nose. You don't do the fork flap anymore. Okay, what surgical technique you will prefer to do in this case?
So Mulligan's method.
Okay, what will be the size of the philtrum you will make in Mulligan's technique? What is the shape of the philtrum and how is the size of the philtrum? That is also one of the principles of Mulligan.
So we will arbitrarily take it as 1 centimeter.
1 centimeter. One of the problem is it will get elongated and widened when the growth happens. So he has reduced it very much. Upper width is around 2 millimeter and lower around 4 millimeter. That is 2 millimeter on either side from the center, depending on the age. What are the different feeding technique you will advise in this child? What are the different options?
So one is by
or injection by syringe.
By the syringe.
What advice you will give in your center?
So by spoon and bowl method, or the Palladai method.
Pallada feeding. Okay.
Palladai feeding. Other than
Why,
that, syringe will be
why
advised.
Pallada feeding? Why not the bottle?
Because these children, they cannot suckle and breastfeed.
There are different bottles also for the feeding. You know any of those bottles?
Sir, Mead Johnson's long nipple.
Now, why we don't advise in our people is cleaning is very difficult. So they will get a recurrent diarrhea. So cleaning of Pallada is much more easier. So otherwise there are different means other than Mead Johnson, there are any other things you know?
Rice tube feeding is an option, but not at home.
Haberman's feeder is there, then pigeon's nipple, so many things are available. And what other than the Pallada feeding, what other important advice you will give the mother during feeding?
To give short, frequent feeds and to nurse in proper position and to frequently burping of the child.
Okay.
Time is up, sir. Can go to the next slide.
Yes, please.
So this is a 3D reconstruction of the head and face showing the left body bilateral discontinuity in the body of the mandible, suggestive of one parasymphyseal, left parasymphyseal and right body of mandible fractures. It is displaced with type 2 malocclusion, sir.
So it's basically you cannot comment on, I mean, this is displaced and not in occlusion.
Yes.
So any other way to characterize the fractures?
So,
any other point to characterize the fractures?
So there are favorable and unfavorable mandibular fractures. They may be horizontally or vertically. Favorable are those
This,
where
I'm not asking you what are the types. In this case,
yes,
how do you describe the fractures? There are two fractures.
yes, sir.
One is by, you can describe them by the site. You have
Site.
already done that.
Yes.
What is the other one? Other way to do it?
Displaced and undisplaced.
Okay. Anything else? So let us first take the, which is anteriorly there. What is the type of fracture is this?
There is oblique.
No. It's a parasymphysial fracture.
I have parasite.
So, for any other way to describe it?
So based on the fracture line, it is oblique fracture.
Okay. Now coming to the other one.
It is horizontal. So on the right side, it is.
Where is the fracture?
Angle. So it is just in front of the angle of the mandible.
Okay.
So why it is displaced?
So this is due to the pull of the muscles.
So relating to pull up the muscle, can you describe this fracture in some other way?
Sir, the unfavorable fractures.
Why?
Because the resultant force of the muscular pull has resulted in a displacement of the fracture fragments.
So how the two fragments have displaced and which muscles have displaced them?
Mylohyoid has and digastric has the central fracture fragment has been moved backwards posteriorly.
Posteriorly and
Inferiorly, laterally.
inferiorly, and the other one?
Right side. Upward. So and the other fragment has been pulled by the masseter upward anteriorly.
So this is an unstable, unfavorable fracture of the angle. So how will you approach this fracture intraorally? If you have to fix it intraorally, how will you fix this fracture intraorally?
So we will give a incision in the gingival sulcus and dissect towards the bone. The muscle will be reflected, and using periosteum, we will palpate for the step deformity, so that we know where exactly to place the incision, and followed by the muscle reflection and periosteal elevation. Then we will reduce the fracture and fix it using mini plates.
No, it's not going to be that simple. Intraorally in the sulcus, you will place the plates on the mandible, and then how will you put the screw? Generally, they are perpendicular to the surface of the mandible. The orientation of the screwdriver is perpendicular to the surface of the mandible.
Yes.
How will you get that orientation here intraorally? Extraorally is fine. Are you aware of the instruments that are required for this? To fix mandibular fracture intraorally, there are certain instruments which have to be used. Are you aware of them? So you have to see those instruments. Difficult to explain. There is a special type of retractor which keeps the sulcus open, and there is a trocar and a cannula which makes a hole from the side, and then you can fix it intraorally. So that instrument you need to know. Otherwise, what is the approach? If you do not have this access, then how will you approach this fracture? By which incision? Externally.
So we'll give a horizontal incision to not injure the cervical branch of the facial nerve. You have to give it 2 centimeters below the margin of the mandible.
Okay. Fine.
Can I add a point? Can I?
Yes, please.
Yeah, this is with due apologies to the panelists. This is a point to the juniors, learners. Just one question I'll ask and then I'll answer myself. The students, to whom you will give incision? Hello?
Yes.
To whom you will give incision? You said you will give incision. To whom?
So on the patient.
No, my point is to make it shorter. Incisions are always made. Okay. I am done. Thank you.
Do you think that there is a possibility of damage to the inferior dental nerve on either side?
So usually it exits at the second molar through the foramen, and this is so on the right side it may be spared, sir.
How the nerve enters the mandible?
Through the foramen, inferior alveolar foramen, sir.
At what level it is?
The second molar.
So you see the fracture line and then you can answer better.
So on the right side, we can see the first, second, third. It may be damaged on the right side, sir.
Why not on the left?
So on this left side, the fracture is it's between the canine and the first premolar.
Is it only the site of the fracture decides or is something else? Site is okay. Anything else?
So if
Is
it
there
is also involving both the cortex, if there is a gross displacement.
You see the upper left picture?
Yes.
There is a overriding.
Yes, sir.
So, and then whole central segment is displaced down because of the pull of the muscles you have already mentioned. Some more muscles are there anyway.
Yes, so there may be impingement of the nerves.
Yeah. So that has to be taken care during stabilization. Do you agree?
Yes.
Sir, time is up, sir. Can we go to the next slide?
No, one thing. What intubation do you use in this patient?
The
I'm speaking
nasal
about
intubation. Nasal intubations.
Why?
So because after fracture fixation, we may proceed with intermaxillary fixation. So there will be difficulty in extubating.
Fixation or before fixation?
So before putting the screws. First, we will maintain
One last
occlusion.
question.
We'll do IMF with occlusion and then fix the fracture fragments.
So, Sir was asking previously, what incision do you want to give when you want to approach it orally? My question to you is, if you want to approach orally for the angle fracture on the right side, and if you want to approach externally by through the skin, is there any difference you put the plates there?
Sir, intraorally it will be onto the alveolar side of the mandible, and extraorally it will be onto the inferior border of the mandible.
We don't put on the inferior border, we put it on the lateral wall only. My question is, suppose if you are approaching intraorally, if it is minimally displaced or not displaced, you can just put a single 4-hole plate on the ridge of it, on the Champy's line, this thing. Whereas when we are doing it transcutaneously extraorally, we always try to put 2 plates or a 4-hole plate on the external wall of the mandible, not on the inferior this thing. That is not the buttress. This thing. Right. Thank you. Let us move on to the next, please.
So these are on the left side picture is micro instruments showing a vessel. There's a arterial venous clamps suction. Is straight. So straight scissors. Then there is a dual forceps.
They are all numbered. You can say what is A, what is B, what is C. By that you can tell. It will be easier.
A is straight scissors, sir. B is a dual forceps. C is.
It is not jewels. It is not jewels. It is jewelers.
Jewelers. Sorry. C is needle holder, sir.
D.
D is vessel dilator. And E is clamps. Different size clamps, a single clamp and double clamp, and F is suction cannula. And the other photograph is showing surgical loops.
What are the types of clamps that are available? Microsurgery clamps, we have them in 5 sizes. Can you please tell me the sizes?
So clamps, they may be arterial or in venous clamps, and they come in 2A, 3A.
And routinely what we get is B1, B2, B3, HD and RD. We use A or V after it to specify whether we are using for artery or vein. Though the venous clamp, we can use it for both artery and vein also.
Yes.
What did you say about F? F.
It looked like a suction cannula.
Suction cannula.
Are you sure?
Yes.
Another suction tip.
No.
Suction tips are not so narrow.
Fine.
No. Yeah. What is it?
For irrigation purposes. During anastomosis.
Where it is connected to?
Syringe, sir?
Yes. Go ahead. Go ahead, sir.
So, differentiate
do you know any
Jollner's forceps and vessel dilator?
aware of any modification in the
Sorry, sir?
Sorry.
Yeah, how will you differentiate the Jollner's forceps from the vessel dilator?
Go ahead.
Vessel dilator.
So the tips
you
are
aware of-
different.
Yeah, what is the difference in the tip? That's what I'm asking.
So the vessel dilator is more thickened and has an inward wedge.
It is more blunt and outside surface is round and smooth.
Rounded and smooth.
So in the one which you're telling D, it looks like a microvascular forceps, means not a vessel dilator. What are the two projections seen in that one inside? Can you tell what it is?
Name them.
So it name I'm not sure, sir. It is
That is
to
called the
prevent
guide pins.
crushing.
They are called the guide pins. What is the purpose of that guide pin?
To prevent crushing of the tissue between the.
That will prevent the scissoring movement of your tip, the proper approximation of the tip. Your D looks like a vessel dilator. The tip is little blood. I think the D is a microscopic forceps. In the loop, what type of prism is there in the loop?
Sir,
optics.
type of
Actually,
prism.
it is what optics I mean. That is, it is a.
What are the
what
two
type of
types of
optics is the?
So the
It's a
lens
prism
are
only. It is a
these
prism
are
type.
flipped.
Either Galilean type or prism type. This is the prism. That is.
Did you wear a loop at all?
Yes, sir.
Yes. Then what is the first thing you adjust?
So the interpupillary distance.
Excellent.
Can you tell us a few medication used in your microvascular surgery?
Piperacillin and lignocaine.
2% lignocaine and papaverine.
And?
Papaverine, sir.
And? Heparin you don't use?
Heparin, yes.
How will you prepare the heparin solution? What is the concentration?
So 0.1 ml in 500 ml of normal saline.
How many international unit in 500 ml saline?
So 2500 and 5 ml. So it is
So
1 in 5,000.
5,000 international in 500 ml or 10,000 international unit in 1 liter. What about paparin dose?
So papaverine, we've actually not given it. We will use it topically, sir.
Yeah, how much? How concentration? You will apply it directly or you will dilute and use it? Like a heparin you are using irrigation solution like that. How will you prepare the paparin?
It is not diluted.
60 milligram in 500 ml. That is 2 ampules. 30. That's the commonly used. Because you are doing microvascular, you must be knowing all this preparation.
Dr. Freji, next my question.
Yes.
Yeah. How will you decide, how will you know the magnification of the loop? What is the criteria?
So how will
there are different types of loops. Yeah.
So the types of loops, there are the lens, sir. It is through the lens or the.
I am asking magnification, criteria for the magnification.
So for different surgeries, there may be different magnifications that are used.
That's what they will tell you. Some numbers. How will you identify it? How will you choose?
So it's usually engraved on the loops, sir, like
okay.
4.5.
It is okay. Tell me, it is engraved as 3. How will you understand?
So it is 300 times, sir.
No. Okay, read up.
Okay, sir.
Okay, next. Anybody else?
By which name? Hello, can I speak, sir?
Yeah.
By whose name the approximator is made? The vessel approximators.
Yes. Sorry.
The vessel you are using the clamps, no? By whose name it goes? Hmm? You know of something Auckland?
Auckland.
Huh? You know it?
Yes, sir. We watched videos of Auckland.
So what is zoom in and zoom out in a microscope, not in loops?
So when you zoom in, the magnification is higher and the field of vision is lesser. When you zoom out, the field becomes larger.
Okay, so what is its advantage?
So with higher, the advantage of a higher magnification, it will help with accurate anastomosis or suturing.
Okay. Thank you.
When do you call it super microsurgery? What are the criteria for
1 mm.
1 mm of
0.08.
materials?
0.08 to 0.0.
It's 0.8 and less than 0.8. How these do you I mean, are you aware of the instrument? Is there any difference in instrumentation for super microsurgery and usual microsurgery?
So the suture size is usually different. 11-0 may be used or 12-0 sutures.
So instruments are usually titanium blue color.
And instrumentation, well, what part of instrument will make a difference when you're going for a super microsurgery?
So tips are very fine. Needle holders are also.
It's basically the tip of the dilator and forceps. I mean, those have less than 1 mm of tip diameter. In super microsurgery instruments are usually extra fine because otherwise you'll not be able to dilate the vessel with usual microsurgery instruments.
So you have 3 clamps here. Is there any other modification of clamps that you know of? There's a single clamp and these are approximating clamps. Any other type of clamps that you know of? Any other design of the clamp? The clamps are microsurgery clamps only, but any other design that you have seen?
So there was a curved bulldog clamps are there, smaller bulldog
I'm not talking about bulldog or anything. I'm just talking about these types of clamps only. Any other design which can make your life easy.
So with a
So
lock.
Indian startups are making it.
Yeah. There is an Indian startup which is selling it now. So you can have clamps which can have frames and with 2 small spokes on them. When you ask your assistant to hold the equator sutures, they can be fixed on those things and it's easier to put the sutures when they are stretched out. And the other is there is a Shira clamp also. You see that you type Shira clamp in net and you will get it. It's better to see it first. And what is the difference in the construction of a vessel dilator and a microforcer? What is the fundamental difference?
So the vessel dilator is more blunt since it is entering the lumen, and to avoid damage to the intima, it is more smooth and blunt. The tip is not as pointed as the forceps.
Yeah, that's one. Anything else? Definitely, it's slightly curved at the end. Anything else? See, when the tips of a spiral and forceps, they generally touch at the tip. But a vessel dilator will touch for some distance from the tip. So it forms basically a cylinder at the end when you close it. It forms a very fine cylinder at the end. So when you open it, it just gently opens up a bit of length of the vessel. It doesn't open up as a cone. It opens up as a cylinder. That's it.
The time is up, so can we go to the next slide?
Yes.
So this is ABC. What's the diagnosis and management? This is a defect raw area in the middle third of the leg. The X-rays show there's a fracture of both bones with an external fixator.
9 screws and 1 plate cell.
So diagnosis, the left X-ray initially shows internal fixation that was done with compression plates, followed by a raw area. Probably it was infected and formed a discharging sinus. So this was debrided, and there's bony debridement that is done. So there's a bony defect seen with external fixators. Final diagnosis would be a raw area, leg, middle third of the leg, with a bony defect and external fixator in situ.
And what has been done in C?
So, external fixation. Stapler pins are seen, sir. So probably there was a, and soft tissue shadow can also be seen. So local flap coverage with split thickness skin grafting was done with external
So
fixation.
do you see a bone?
And the bone graft
In
also
C,
is
there are two
bone
X-rays.
graft. Yes.
So what are the possible procedure that is done in this patient?
So LRS for
No.
4 days.
Do you think that is a bone transport or a bone flap?
bone transport.
No. Why it is not a bone transport? Why it is a bone flap? So what are the prerequisites for a bone transport?
So that the adjoining bone should be healthy. There's no active infection.
Communicated
major fracture. And it should not be a communicated. So it should not be a communicated or multiple segmental fractures.
If a transported bone will have a uniform thickness, not only it will not transport in a very small, just 1/3 of the bone is bridging the gap. And there is no other corticotomy or distraction site visible. So what is the probable bone flap? What are the possibilities here?
1 second, sir. I feel this X-ray, because of the superimposition of the native fractured fibula in between the tibia, it is looking like as if the bone has been cut. I think this is just the fibula that is getting superimposed.
Yes, sir.
The lateral.
See, sir.
This can be.
There is a corticotomy, I think, a little above. So this is a limb reconstruction system, isn't it? So
yeah.
Maybe.
No, sir. That corticotomy, that could be because of the previous pins which have been taken out now, and they have removed the previous external fixator and they have put this distraction site. And the AP and lateral views is slightly confusing us. That lateral view is giving us the wrong opinion that a bone bridge or bone defect has been bridged. I think it is the same view, sir.
AP lateral view.
Yes, they're yet to do bone transportation both in this patient.
Maybe that, I mean, we cannot comment for sure, but this much of bone
Pratap
visible
is
in the
correct.
defect.
It is the fibula which is visible from that side.
Yeah, so either,
yeah,
I mean, they could have a transpose. I mean, it may be a case of transverse fibular interposition in between these two, but you cannot say.
There was a compression distraction unit is there on the LRS. So I think they have done initially that debridement of that one and put a distraction. What are the features of osteomyelitis in X-ray? Can you tell?
So sequestrum is there, which is our hyperdense dead bone. Involucrum.
Before sequestrum, what will be there? The first signs?
Periosteal. So there'll be tissue reaction, overlying soft tissue reaction. There will be periosteal reaction that is seen. There will be bone marrow edema, which is more lucent and better appreciated on MRI. And there will be cortical irregularities may be seen in the area of osteomyelitis.
Lyticlation, sequestrum, involucrum, all those things will come later. Sclerosis. Here, what flap you will give for coverage of that row area? Because they might have removed the plate and put a flap. So, what flap is possible in that area?
Sir, a gastrocnemius flap, muscle flap with, since the staples are seen, it looks like a muscle flap with overlying STSG is done, sir.
Will the gastrocnemius reach at that level?
The middle third, the muscle and the musculotendinous junction will be seen. Usually it is better for proximal third and upper part of middle third defects, sir.
In this particular case, will you think the gastrocnemius will reach at that level? Look at the X-ray. What level is the?
So it is lower down, so it is unlikely that a gastrocnemius, maybe a soleus muscle flap could have been maybe used. Other options can be faciocutaneous flaps that may be done. But since the pins are seen, so probably a muscle flap with STSG is done.
So what is the blood supply of soleus flap? What type of flap it is?
So type as in Mathis and Nahai classification. Type 4, sir. It has a single dominant and multiple segmental. Type, sorry, one dominant and one non-dominant. So type 2, sir.
So what is the dominant pedicule?
Soleus supplied by popliteal arteries.
Sir, time is up, sir. Can we go to the next
Just
slide?
1 second. Likita,
Yeah.
1 second.
Yes, sir.
Likita, 1 second. One simple question, basic question. What is the definition of sequestrum?
Sir, dead, demineralized and calcified bone.
Okay, shall I? For the
Dead bone
benefit
in
of
a
the
living bone is sequestrum.
Yes, that is, it is sequestrum is a dead bone
In a living bone.
is present in a living bone and separated from it by blood or tissue fluid. Over.
Let's see what is your diagnosis? Sir, since it is a middle-aged female with a lesion of 4 months duration with history of high-risk habits like tobacco chewing, I would like to make a diagnosis of a malignant lesion of the upper alveolus. So carcinoma, which is the most common form, is squamous cell carcinomas occur. So squamous cell carcinoma of the upper alveolus. I would counsel the patient by saying, firstly, I would tell the patient that the lesion may be malignant and it may be further confirmed by tissue diagnosis. And if it's a malignancy, we will have to stage it by radiological investigations. I would like to counsel her regarding the nature of the disease and the multidisciplinary team that will be required for her to plan her further management. For staging of the disease, need for reconstruction, post-operative radiotherapy may be required, and the amount of resection. Other risk factors, like if she, according to her, if there will be anticipated blood loss, so we will have to arrange blood. And post on the long term, this is immediate post-op, and long-term post-op, she will require therapy for speech therapy and even for swallowing, sir. And what are the options for this condition? So the treatment options are broadly classified as surgical and adjuvant therapies, that are chemotherapy and radiotherapy. Surgical would be wide local excision that would involve the lesion and part of the maxilla. There are types of maxillectomies according to the Corrido or the Brown's classification. Followed by we would anticipate the type of defect and plan a flap accordingly. We would like to see if it is only alveolar or a hemipalatal defect or a total maxillary defect, and counsel her regarding the need for flap reconstruction. Also offer her the option of a obturator in case of palatal defect, and the possible incision and scarring the location. There may be local flaps or regional flaps or free flaps that may be used. What is the stepwise operative management plan? So first I would like to get a tissue diagnosis. Once, if it's a malignancy, I'd like to stage the disease. Based on the stage, we would proceed for surgical resection. According to CT and MRI. If preoperative radiotherapy is indicated, then we would like to give that first, then proceed for surgery. So the surgery here, we would proceed for wide local excision with a clearance of 1 centimeter. So the anticipated defect would be a hemipalatal defect, and maybe the inferior wall of the maxilla. This can be reconstructed by so type 1 maxillary defects can be reconstructed by a radial artery foramen flap if only soft tissue is required, or even osteocutaneous radial artery foramen flap can be used. So should we describe the full surgery, sir? Flap marking, elevation, microanastomosis.
No, not full surgery. I mean, there's not that much time. You, what are the options you said? You will prefer a radial artery forearm flap.
Yes, sir.
So what will be your bone requirement? Will your radial artery will actually be able to give that much bone?
So osteocutaneous radial artery foramen flap may be used, sir.
So what is the maximum width of the bone flap you get in a radial artery forearm flap? And why radial artery forearm flap for bone is not a good choice? What are the limitations in the radius bone when you do it for a bone flap?
The width is less, sir. The other disadvantage is donor site morbidity, and the perforators are limited.
So if width is less, what will be the major disadvantage in this area?
Yes.
What will be the major disadvantage in this area for a bone reconstruction? Because you have to do something later on.
So we could
this is alveolar area. So what do you do later on in alveolus?
Alveolar bone grafting can be done.
You will require to place implants or some dental restoration.
Obturator,
Radial artery,
dental implants.
Radial artery forearm flap bone is not good for any implants to place. So it's better to, most of the places people will go for fibula osteocutaneous flap in such condition. Fibula will give you enough bone and skin pattern on both sides.
When you take the radial artery osteocutaneous flap, the whole circumference of the radius will you take? Number one. Answer that.
Circumference.
What percentage of thickness you will take? Sir is asking that. Right, sir?
Yeah. And the second question is how the radius, when you take this flap, how the radius is getting blood supply. In a radial artery osteocutaneous flap, how the radial bone radius is getting the blood supply. How will you protect the blood supply or ensure the blood supply to the radius?
So there will be perforators that we should not damage, and there should not be excessive shearing of the septum from the periosteum, sir.
So for that, what precaution will you take to ensure that they are not damaged? That's what I'm asking. Okay, carry on.
Sir, actually, time. Yes, sir. We can ask one more question and we can go to the next one.
Basic difference in blood supply of a fibula bone and radial bone when you take a split radius.
Sir, sorry, I did not get the first. Difference in blood supply, sir?
In blood supply of bone of fibula and the split radius, because you always take a split radius. You don't take full radius.
50%, yes.
So what is the basic difference in the both blood supplies? What sir has asked.
Fibula has multiple nutrients. So fibula has multiple nutrient artery branches, and since it is taken, the whole of the bone is taken, the blood supply it's more vascularized and more viable.
So fibula is covered with, it has a periosteal supply all around.
Yes, sir.
Which will not be there in a split radius, and the bone stock is very thin. We can.
What postoperative care you will do it and follow up? Suppose you take a vascularized free fibula.
So immediately post-op, sir, we would keep the patient NPO. There will be hourly flap monitoring that is done.
How? How?
Sir,
Clinically, how do it?
clinically, on inspection, you see for the color of the flap. On palpation, you see for the turgor and the warmth of the flap. Also, you can do a pinprick or a scratch test look for dermal bleeding.
Which is better, pinprick or a scratching? Which is more authenticated, more reliable?
So scratching, because we're looking for the dermal bleed, so which is slow brighter.
Okay, go on. Then?
And then other methods of monitoring, you can do a Doppler radiologically. After that, regular dressing and oral hygiene with chlorhexidine mouthwash. Rice tube, which was inserted, rice tube feeding can be started. And so other than that, other than flap dressing, monitoring, and feeds, IV antibiotics will be given. And the donor.
Indication for intervention. While monitoring post-op, what will be your indication for intervention.
Intervention, sir.
Yeah.
Sir, if we see any color changes that are suggestive of venous congestion, or there is no bleed on scratching and you suspect there's arterial thrombosis, then initially if there is congestion, we may release some sutures and again monitor. If there is no improvement, then the patient should be re-explored immediately and the anastomosis should be revisited.
Yeah. Thank you.
So shall I go to the next slide?
Yeah.
Yes. Go ahead.
How would you document all the aspects related to this lesion?
Yes, go ahead. How will you document all the aspects of related to this lesion? Then further you can add later.
So this is a case that seems there is a maxillary hypo. It looks like a case of hemifacial microsomia. There is maxillary hypoplasia on the left side. So I would like to ask history first. Is this a post-traumatic deformity or is it congenital? Because there is a DNS also.
No questions are allowed. It is a documentation slide. But you can see in the pictures. How will you document all the aspects? Because documentation is very important.
Okay, sir.
Right?
So
You
I
have
would
to,
take.
how will you document all the features which are visible to you in these pictures?
Yes, sir.
Secondly, when you get all these lesions, all these aspects, all these findings, then how will you investigate the case? That will be the second thing. So first, how will you document all the pictures, all what you see here? No
You
need of any.
enlarge the picture and you can make out. You enlarge the picture and you can make out.
Right.
You enlarge the picture.
Zoom in.
So I would document all the history that the patient is given on an examination. On inspection there is gross nasal deviation, and the dorsum of the nose is shifted to the curve to the deviated to the right side. There is flattening of the left zygomatic arch and the maxilla, the maxillary prominence.
What else?
In which cases you will take these sort of photos? You've taken frontal, lateral view, above that.
Worm's eye view.
So
Worm's
basically,
eye
how
view,
to
how many
analyze the nose?
Nose, yes, sir.
Worm's eye view, only one is taken. It should be
For
taken from the feet end also, foot end also.
Yeah,
foot
basal
end,
view
sir.
also should have been.
For nasal, foot, yes. So the worms are used to look for septal deviation or columellar deviations. So this looks like a case of traumatic DNS. I would document the gross deviation in the nasal dorsum at the site.
What is the shape? What is the shape of the deviation? How do you describe?
shape. So S-shaped deviation. The
Are you sure?
dorsum. So the columella, the tip of the nose is still in the midline, and the dorsum
Exactly,
is.
that's very important.
So it's a C-shaped, sir.
It is
C-shaped only
C-shaped.
the.
You're right. Go ahead.
And so after we would investigate, we would ask for an NCCT of the face with 3D reconstruction and also the
Don't you
PNS.
document the breathing? Don't you question the patient about the breathing? Is he able to breathe through both the nostrils? Is there any difficulty or not?
Yes, sir, I would document the history, the
Your maintenance.
etiology, what was the cause and what are the current symptoms he's having other than the aesthetic problems. If there's any functional deficits like frequent URI, if there's breathing difficulty, any frequent discharge or any bleeding from the nose. Was there any history of CSF rhinorrhea at the time if it was traumatic? If he had any history of loss of consciousness at the time of trauma? And if any surgical manipulation was done, if he received any treatment?
Any other? Any other?
So then we would.
Allergies.
If you asked for CSF rhinorrhea, why you did not ask for loss of smell?
Yes.
Yes.
Anosmia.
Anosmias.
Also, allergies are very important.
Please, next.
So investigation, I would like to get a 3D reconstruction of CT of the face along with basic routine blood investigations for surgical workup.
After your history, you need to document external deformity as well as the internal problem in the nose, and you need to look for the functional issues also. And the documentation should be either you start from above down from the radix to the tip up to the lip, or you come from down above. So your documentation in the frontal view, documentation in the lateral view. So you must, rhinoplasty documentation is very important. So each type of the skin from the radix, bone, mid-vault, your dorsal line, your tip, your columella, your ala, everything you should width, isn't it? All those documentation is important.
Also, what is the patient's prime concern? Is it shape or breathing or
Function
both
or
or something else? Pardon me? That is very important. The reason being, whether that gives an idea for you, whether you can fulfill his requirements, then you document both. Patient asked this and I told this. Patient agreed or not, that also you have to mention and take signature.
Functionally, what test you will do to assess the nasal obstruction?
So Cotton's test.
Cotton test is for evaluation of the internal wall. Okay, continue then.
Sir, how will you investigate? Get basic routine blood investigations for pre-anesthetic checkup and for the face, NCCT face with 3D reconstruction.
Before that, anything important? Photo documentation and anything
Sir,
you will
endoscopy, nasal endoscopy and
do? No, always in rhinoplasty, make the patient take the photos and you discuss with him what is his expectation. What is Simon in rhinoplasty, the term Simon?
Obsessive narcissist, single male obsessive narcissistic
Single immature male, overly expectant and narcissistic. So you need to actually document in the photo, ask the patient whether expectation, what they are expecting, make the mark it on the photo, or you can have a computer thing, you can show them what are the changes. Okay.
Marking is very important in the photography.
Okay, here, what all things you may have to do in this case? What all correction you may have to do? And what approach you will go for?
Sir, the nasal dorsum correction will be required. We have to see if if it's involving the nasal bone, if it require a lateral osteotomy or not, and
Is the nasal bone is involved or not? The visibility is in the photo.
it is involved, sir. But from the clinical photo, it is involved. So it will require lateral osteotomy, and for the dorsum correction, the septum correction, if there is a deficit in the cartilage, then we'll have to take a cartilage graft, which can be taken either from the concha or from the rib. The approach would be a closed rhinoplasty, a transcolumnar approach by a step incision or inverted V incision.
That is an open rhinoplasty.
That is,
Sorry,
you are confused.
sorry, open.
You are confused with both. You are telling closed and we say step or V.
Sorry, open.
They are two different things.
Yes.
Which is your approach? Closed or open?
So open.
Yeah, you're right. Such a drastic change, it is difficult to get it through closed approach.
Do you expect any septal deviation in this case?
So the inferior half of the nasal dorsum is slightly tilted, so there may be some amount of septal deviation.
If it is a post-traumatic, what type of nasal bone fracture is that? Type 1, type 2, type 3 nasal bone fracture. This is a lateral blow, so normally it is a type 2 fracture. Definitely it will be associated with the C-shaped fracture of the septum, which is called the Jarjave fracture of the septum. Type 1 is associated with the Chauvet fracture of septum. So here it is C-shaped fracture will be there. You need a septal correction definitely.
Can you use a CAD-CAM technology in this case for documentation and futuristic about the outcome of your surgery?
Sorry, sir, I don't get it.
CAD and CAM technology, can you use that software for using and forecasting the outcome of the surgery? CAD and CAM technology.
And has a computer assisted design and computer assisted manufacturing. This usually is used for craniofacial procedures where the facial architecture or the bones are to be advanced. The template is created and implants may be designed so as to bring about the adequate projection that is required. Sir, in this case, if it may be used to see if the septal cartilage, how much is there and how much we need, and how much of correction to the midline is required.
Oh, it is not used, but it can be used. Commonly is used, as you say, craniofacial, it is more used, but this can be used if you have a software for that.
We are talking about the documentation. How will you close the documentation and end sentence?
So that the risk and prognosis and possible outcomes have been explained to the patient in his own vernacular language.
Okay. I'll tell you. no guarantees are given. You cannot predict 100% how they are going to settle and then how the patient is going to react for that. One of my patients with 1 millimeter projection, palpable projection that is not even seen, they are not able to tolerate that. So if you write no guarantees are given and then take patient signature and then one more witness signature, you are more safer. Over, sir.
So can we go to the questions on chat box, sir? Or
Yes, time is up for this, all the spotters. Thanks a lot, panelists. So we can go to the questions now. Yes,
The cross questioning is over.
Yes, sir.
Cross questioning by other teams.
That is over. That was bit after the discussion, sir. After the discussion, we took that.
Okay, fine.
Now we'll
Go
see
ahead.
if any question is unanswered in the chat box. Dr. Likhta is seeing that.
there's just only
Most
one.
of them,
So only
the
one.
rest is answered.
Yes, sir.
Okay.
So kindly suggest the radius length that can be safely harvested for osteocutaneous radial forearm flaps.
For radial artery forearm flap, we usually take just 1/3 of the width, and the length, if you see the perforator which actually touches the periosteum, it cannot be more than 5 centimeter in my opinion. Just maximum 5 centimeter of bone with 1/3 of the bone thickness. That will probably be safely, you can take it. Otherwise, the risk of radius fractures will be very high.
Now, any questions by the delegates and other faculty in the
Dr. Omar, can I ask a question?
Yes, sir. Yes, sir. Please, sir.
Regarding the last case, can I ask a question to the candidates? How do you examine the preoperative examination of nose inside? What do you mean by the terms anterior rhinoscopy and posterior rhinoscopy?
Anterior rhinoscopy by using nasal speculum, thoricum nasal speculum.
So how do you hold the nasal speculum?
So it is a U-shaped, like a hairpin shaped thing. So you hang it first, and then
with middle
compress
and
it, insert it, and then you release, so it holds the ala distally.
And you have the headlight on, right?
Yes.
And how do you do the posterior rhinoscopy?
By an endoscope.
No.
Lens. From mouth, sir.
Yeah.
The lens.
Indirect
laryngoscopy.
You make the patient comfortable and tell the patient to open the mouth and take a dry gauze piece and hold the tip of the tongue. Then take a warm mirror, not hot mirror, warm mirror at the posterior side, just anterior to the posterior phalangeal wall. So you can see the posterior part of the septum. It takes some time. It has a learning curve. So that's what's meant by posterior rhinoscopy. So this is very important, as Dr. Venkata has told you. In the documentation, you have to start with external examination and internal examination. The external examination, you start with the skin, the root of the nose up to the tip. Then you see for any bumps or projections, all right, any hump. And this, your best thing is to document, to divide the nose into 3 parts, upper 1/3, middle 1/3, and lower 1/3, right? And then you proceed with the anterior rhinoscopy and posterior rhinoscopy. That will be a complete examination of nose, right?
Thank you, sir.
Thank you, sir.
1 second. 1 second, sir.
Yes,
Nase
sir.
endoscopy. What is nase endoscopy? To the students.
Sorry, sir?
Nase endoscopy.
Sorry, sir.
Endoscope inserting into the nose nasal cavities. And then you can record it. And then you can document it. You can save the recordings. It gives much more details, many more details. Okay, go ahead. Go ahead, Dr. Umar.
Yeah. Thank
Yes,
you.
sir. Thank you, sir. Any other questions from the audience? So we can move now to the panelist remarks regarding the performance of the postgraduates as well as the opinion about the Plastiquest. We'll start with Dr. Samik. Sir.
Yeah, this was it was quite well conducted by you, and the content was pretty good. A very wide variety of cases have been discussed. I didn't know the which year the students are. They are third year students.
Second year, sir.
We are first year and second year.
First and second year.
First year and second year.
For first and second year, the performance is reasonably good.
Excellent.
Had it been third year, then I would have said something else.
True.
Fine, that's it from my side.
Thank you, sir.
Yeah.
Dr. Brijesh, sir.
Thank you, Dr. Uma. This was actually a very nice session and compilation by the team, because it covered almost like a full MCH exam. A lot of things you have covered, except the cases, spotters, everything. And just now when you have told that these are first year and second year student, I think they have performed reasonably well, because first year and second year, you don't expect all those operative steps. So those are the things probably they will be, once they will be gaining hands-on and clinical doing cases, they will be mastering those things. But their basic knowledge seems to be good.
Thank you, sir. Dr. Fiji, sir.
Yeah.
Dr. Nasida and Tasvir, you have done a good job, and your knowledge in case analysis is good, and your clarity of communication is also good. And keep up the good work and continue to build on your strong foundation. And to the Plastiquest team, I want to acknowledge your exceptional work. I think in organizing this education platform, you have covered almost all the topics, important topics in plastic surgery. I think it will not only benefit the students, and it will greatly enhance our collective learning experiences. I think as a faculty, I also learned many things from even the students as well as from the faculties, others. Anyway, thank you for inviting me for as a faculty also. Thank you.
Thank you, sir. Dr. Pratap.
No, it was both the students. You have done very well. Dr. Samik Bhattacharya sir is a very tough judge. Even if you're third year also, I would have passed you.
Thank you, sir.
And this thing, presentation was good. I also thank Dr. Farooq and Dr. Likita.
No, I didn't mention about failing anybody.
No, I was just joking.
No, it's not like that.
No, I understand, sir. I was just joking.
In a lighter mood, sir is saying that sir is a tough examiner.
Of examination now is better.
Oh. No, if
yes, sir. Dr. Pratap, please continue.
Any of you both students, if you have any questions to us, faculty, we'll be more happy to answer.
Thank you, sir. Dr. Likita, can we go to the short presentation? Dr. Pratap, you want to continue something more?
No, I just want to thank Dr. Farooq and Dr. Likita also for doing it well.
Thank you, sir. Dr. Likita, can we go to Dr. Ratnam's short presentation and first introduction, short introduction?
Yes, sir. I'm just displaying it, sir.
Okay.
It was a last minute thought, 11th hour thought, totally unprepared. Yes. Because it is related to scalp. I thought this may be appropriate for this occasion. So I offered, and both Dr. Farooq and Dr. Umar and Dr. Likita have kindly accepted. Okay.
Pleasure, sir.
Okay, good. Okay. Dr. Likita, next slide, please.
Yes.
Next slide, give me that with the tapes.
Okay, sir. Yes, sir.
Ulcer with tapes. Or dry area with tapes.
Yes, sir. Just a second. Yes.
Yeah. This is for the PGs. I told you with the, you have to take a picture with the 2 tapes, either fixed or held that, and in 2 directions. So this one is very, very important to start with. This is pre-operative. And post-operative, there are, as you know, many ways to know the progress, how much it is progressing or not. So you can keep the same technique to document the progress, number 1. Number 2, this much is not a good idea for a conservative treatment. So if this area is smaller, slightly smaller, and the patient is apprehensive or wants to try non-surgical means, how it is useful is, there is a criteria of the progress of the epithelium. And then below the epithelium, subdermal and dermal tissues, they will follow later. So whether it fits into the criteria or not, you can document it. And then you can say, because of these criteria, I have taken a decision to continue non-surgical treatment as requested by the patient. Otherwise, because of these criteria, I told the patient, well, it is not worth trying it, we have to go for surgery. This is the importance. Okay, Dr. Likita, next. Give me that article.
Yes, sir.
Yeah. Full screen. Yes. Okay. Yeah. This part only, can we make it full screen? Can we enlarge?
Yes, sir.
Yeah. Okay. So this is again, as you know, it is a scalp case. This patient is about a 26-year-old patient. He was having a small swelling on the top of his head, and it was there for about 14-15 years. Then for the past 3-4 months before presenting to me, it started increasing in the size with the pain. He is unable to sleep also. And over and above, the rider is, he is going to get married in 6 months' time. And then he doesn't want any non-hairy area, no skin graft, nothing. He doesn't want to wear any scalp additions or hair additions. So that is a challenge. Well, 1 second. Okay. This is about the, so I cannot excise it and put a skin graft and expand the skin sideways, mixed skin, and then do several operations and then send him with the full dose of hair before his marriage. So that was the challenge. And he was crying. He was unable to sleep, pain, daily increasing. So what I did was, this is the mark. Can you see? Dr. Likita, can you bring down the upper 2 slides? No, upper 2. Yeah. So when the hair is grayed here, and then you can see the difference between the hair over the tumor as well as the hair. So it is growing bigger and bigger. Then the Dr. Likita, can you give me the other measurements? In this? No, not in this. Okay, fine. It is 13 centimeters into 14 centimeters, for example. Please bring it down. The suspense is gone. Yeah. So that is 13 centimeters into 14 centimeters. Can any pages suggest how should I deal with it? That much flap you cannot get in a single stage. I mean, multiple stages not allowed. He doesn't want hair additions because his uncle, I mean, going to be father-in-law, he is very strict. If he knows that there is no hair on his head, he thinks that he is having cancer and he will cancel the marriage. So that is the threat. Okay. Now it is 13 into 14 centimeters. Now, Dr. Likhta, please take it up. And can you put the latest one? My latest figure I sent to you. Only the frames. Only the frames.
Just a second.
No, not here.
Yes, sir. I'll just open it.
Yeah. Latest one is only the frame.
Yes, sir. I'm just opening that.
Yeah, please. Yeah, is the one. So my target is side to side. It is 13 millimeters. At the most, you know that 1 millimeter. So per day. Then tissue expansion, we cannot get it by any means. So what I did was, I told the patient, there is a technique based on tissue expansion principles. I will try that. I have done several things for years together on other parts. Scalp, this is the first time. I don't know that tough scalp, whether it will come closer or not. This much, whether I can do it or not. On the other hand, if I can make it smaller, at least you can grow the hair longer and then manage somehow. And then he agreed. Basically, he wants to get it. The first thing is get rid of the swelling, get rid of the pain. Second thing is as much as possible. So what I did was, this is these are two rods, these K wires, and this is the L screw. These are the things. So what happens is, if I introduced these K wires on either side, and then front and back I connected to this. So usually these are 2 or 3 varieties will come. 1, 2, 3, 4 is the commonest one. Now it has got 5 or 6. So whatever it is, if it is 1, 2, 3, 4, what we can do is, we can dress the whole area. Area in between, before this is, within the frame is raw area. So you can do the dressing by all aseptic precautions, and then make a small hole on either side, so that the patient or patient's roommates can turn 1/4 turn in the morning, afternoon, evening, night. That means 1 millimeter. 1 full turn is 1 millimeter. So you apply that and then close the area, make it sterile, and then ask the patient or bystander to just turn it. And then I used to call him periodically and then check it. So this, but Dr. Likhta, can you take it up? Elite up. The same figure. Can you take it up? I mean, I want to present the lower part. Same picture, same frame.
Okay.
Okay, if it is going to take time, meanwhile I'll present and then I'll go to the next point. That means as the screws are being turned, the K wires will come close to each other towards the center of the wound by 1 millimeter per day. So the distance will be less. Then what happens is, because the scalp tissue is very tough, the sort of cutting through will happen. Also, by the time the distance between two K wires is also reduced. So you can go for a smaller screw rod, that one, and then it will be much easier to do the dressing and for the patient to sleep also. So like that, once only I changed it, and then completely I closed it. I closed it by 90 days. Within 90 days, patient gave me 120 days, and I closed it by in 90 days. But click the next again, article again, article.
Yes.
Yeah. So this is the one. Yeah. You see, this is the full picture, and then this is the starting point. Next. And then this is the one I told. And then here, the smallest available. When it came like this, I closed it. And this is the one which he sent after marriage. After 2 years after marriage. So this is the final result, ultimate result. So this I wanted to present to you. Thank you.
Thank you, sir. Beautiful result. Thank you, sir.
Thank you.
Sir, question is in the chat box regarding this. How do we decide points of inserting the K wires?
Yes, it's a important point. 1 second, let me, the whole thing left. Yeah. Okay. Dr. can you put that back?
Plastic.
Yeah, journal picture back. Yeah. You see this. See, probably because of this, I don't know who asked, because of this, that question came. You don't have to put the whole thing because the bone is curved. And if you curve this, what happens is, at some point or the other, they will twist the direction from here, and then you will not get it. So 1/3 of it I have chosen, 1/3 of it I have chosen, and then I moved the skin from side to side. So 1/3 behind, 1/3 in front of the posterior part, approximately. And then it has to be through the dermis, reticular dermis, intradermal reticular dermis. It holds reticular dermis very well, and it won't give any external wound because of that. If you are in the superficial dermis, it will cut through, and then it may even project in some parts. So this is the technique for introducing the pins, K-wires.
Thank you, sir.
Thank you.
Can we now have the final comments by our patron, Dr. Bhattacharya, sir?
Thank you, Dr. Umar. Regarding the scalp cases, scalp defect, I just wanted to mention to the students that you must understand the importance of anterior hairline ultimately. Once you cure the malignant lesion, then you have to think of that also. And I agree with Dr. Pratap that you can spare the right side scalp as much as possible for the future tissue expansion, and use the left temporal flap for cover. If it falls little inadequate, you can always use 2 flaps. Always keep in mind, any defect anywhere, it's not necessary that you have to cover with 1 flap if you are using a local flap. So you can have 2 flaps. Second thing is, whenever you do such a tissue expansion, single or 2 or sometimes 3, you must explain the patient that for next 6 months she has to lie prone, and she will agree. He or she will agree, because it's the question of the rest of the life. So that is another thing. Then always when you put the tissue expander, there will be a capsule. And there's always a controversy whether to excise the capsule, incise the capsule, or keep it as such. Answer is nothing is to be done. Keep it as such. Because if you try to excise or incise, it causes profuse bleeding, and that leads to unnecessary complication. Regarding fracture mandible, again, Dr. Pratap was asking about the external approach, which is quite valid. And always remember, it is a monocortical plate fixation. It's not bicortic. So that answers many things, that protects many things, like the inferior alveolar I was asking. Then regarding the CA alveolus case, about the inclusion of the radius, as Dr. Brijesh was telling, about 30%, maybe up to 40-45% you can take of the circumference. But the question which I asked is how to ensure the blood supply. You keep a cuff of FPL, okay, with it, and that ensures the blood supply because it is basically the musculoperiosteal supply. So that trick is very important. And regarding the last case, you jump to the conclusion it is a post-traumatic DNS. Okay, so when you start using all these abbreviations, you make mistakes. You say it is not only DNS. That's an additional factor. There is definitely a fracture of the nasal bone on the left side. And in this situation, the most important, one of the most important aspect is that when you operate these cases and do septoplasty, one of the most important aspect which sometimes is ignored is the protection of the mucosal flap. You raise a nice mucosal flap, otherwise you lead to septal perforation, and the patient will remember every day with that complication throughout life. It's very difficult to manage septal perforation. So this is the